Testing our first surgery for this day, live from Deuk Spine Institute, Surgery Center, Viera. And our first patient is having a cervical Deuk laser disc repair at C3-4, C4-5, and C5-6 and 6-7. This is actually a 4-level. 6-7 is the least effective. And the problem we're going to have is that this patient has a very thick neck, short neck. I feel like we can get safely 3 of them. I'm still going to have to, the jury's out on shot on the bottom disc, because the shoulders, you can see the shoulder are coming up all the way up to 4-5. So our patient has basically 4 herniated discs, and the worst 3 are the top 3, which fortunately we can get to. And there's a reason for that, by the way. Does anyone know? The reason is because the lower disc, 6-7, is actually stabilized by the shoulders and the clavicle, and it's relatively immobile. So people get herniated discs because their spine moves. If your spine didn't actually move, you'd never have a herniated disc. So it's actually movement that promotes herniation and injury. And the discs that don't move very much don't usually get herniated or damaged. So the top of his neck, because he has a short neck, basically takes all the movement, and it doesn't distribute the movement down to the bottom part of the cervical spine. And so the top of the neck, the first 3 discs, are really taking a beating throughout life when it comes to abuse and use. All right, we're going to do a discogram shot. Let me get a little pull and shot. You can see the dye went in. There's a tear in the back. It's not entirely obvious, but let me see if I can do a better job. Luis, give me a little injection while I pull down on the shoulder. Shot. Give it. Shot. You can see the tear back there. Yeah. Yeah. Okay, so I can see a tear in the back of the disc. Again, you count from the top of the spine, C2, 3, 4, 5. We are at C4, 5. So, and do an AP. So we're doing a lateral view and an AP view with an X-ray. The X-ray we use in the operating room is called a fluoroscope, and we use literally the top fluoroscope in the world. So you can see, show them the dye leaking out through both foramen. So he's got a bilateral tear there, yep, and there. Show them the nerve root, that little arc there, yep. There, yeah, see how it arcs down, that little dye there? Yep, that's the nerve root. So this patient has at C4-5 tears on both sides. These are called annular tears, and that's what we're here to fix today. We're going to be doing an annular tear debridement. We're debriding the annular tear. By doing so, we should be able to eliminate the neck pain, and by decompressing the nerve roots, we're going to eliminate the arm symptoms. So there's 3 things we want to achieve. We want to eliminate arm symptoms from radiculopathy or nerve impingement or irritation, myelopathy, which is spinal cord compression or irritation, shot, and neck pain with headaches. Not everybody has headaches. Headaches come from dural irritation by inflammation. Shot? Okay, so our guide wire is now inside the disc at C4-5. We can easily see C2, C1, C3, C4, C5. So I'm starting here at C4-5. I'll work my way up to 3-4 and then down to 5-6 as well. We're going to make an incision after we numb up the skin, okay? So take a look here. The whole surgery is going to be done through a 4mm incision. I may have to make 2 of them. Everything okay, guys?
Just EKG when we were just taking the shot. Got it.
All right, so I've injected 2 cc's of local. Our local contains lidocaine, marcaine, and epinephrine normally, unless they're out of national shortages. I'm using an 11 blade to make a 4mm stab incision, just so you can see what an 11 blade looks like. It's a sharp, pointy blade, almost looks triangular. and I set it right at the where the needle is entering the skin, and go in and do a 4mm incision. So at this point, we're going to need some more x-ray shots. Luis, pull the shoulders. Now my goal here, as I'm taking the needle out, is to make sure the guide wire stays in. I don't want I want to anchor the guide wire. There we go. And I'm going to just twist out this needle, leaving the guide wire in place. Perfect. Okay. Now, why don't you show them, Kevin, the audience, how herniated discs actually cause neck pain?
Yes, sir.
Cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, I got to get the dilator back to the back of the disc. And let's get an AP. So people wonder, why are we doing this spine surgery? And I mentioned it earlier. There's really technically four things that we're trying to treat. And every patient's a little different, but the one thing we're trying to treat, the first, is arm symptoms from nerve root irritation or pinching. We call that radiculopathy. And the arm symptoms can be weakness, like in this patient's case, numbness, tingling, or even pain shooting down the arm, okay? So arm symptoms are a very common reason to do cervical disc surgery of this type. All right, that looks good. The second reason is compression of the spinal cord causing myelopathy. Myelopathy is dysfunction of the spinal cord. It can come from various reasons. One of the most common is compression or from spinal stenosis or cervical spinal stenosis. So cervical spinal stenosis with spinal cord compression and dysfunction. The third is neck pain from the disc, and the fourth is headaches from the disc, herniation. So those are the 4 things that we're trying to fix with every patient, and not every patient has all 4. Everyone has a different combination. The most common is neck pain. Second most common is arm symptoms. Third most common is headache. And the 4th most common is myelopathy. All right, we're going to be advancing our tube. It's a 4 millimeter tube. Thank you, Luis. The tube that we're doing the whole surgery is going in now. You can see it passing through the disc space. Sean? And again, I just slowly advance it, keeping an eye on the dilator tip. Can you give me a little shoulder pull to make sure the dilator's not going anywhere, Sean? Yeah, that's perfect. You giving me inline traction?
Yes.
Yeah, inline traction. Stay with it. That's perfect. Keep going. Sean? Sean? So the reason why I'm having a little difficulty advancing this tube is this patient has, stay with it guys, this patient has clearly a lot of scar tissue inside this disc. So how would he get scar tissue in this disc? Oh, that's very nice. The answer is inflammation. And why would there be inflammation? And the answer is, stay with it, stay with it. You got him? Sean? Is there's a tear in the back of this disc. Sean? Man, that's a tough one. It's a really compressed. That's about as good as I'm going to get it right there. All right, let's see how that is. If I need to put the dilator back in, I can. But you could see I was hitting that pretty hard, okay? Why? Because here's your bones, like this, and there's a disc between them. It's soft cushion and allows movement of the bones. We're going through that disc, but if the disc is super scarred up from chronic inflammation from the annular tear and herniation, then it literally will scar the bones together, and they will not separate. So the first thing I asked my anesthesiologist was, hey, is the patient relaxed? Because there's 2 things that will pull the bones and hold them together. The muscles in the neck tightening down and compressing, and that means the patient doesn't have enough muscle relaxation, or the other thing is just scar tissue from inflammation. And in this case, it's scar tissue from inflammation because his muscles are really relaxed. Very nice, 0 twitches. All right, so you're going to see something very fascinating with the Deuk laser disc repair as opposed to a fusion, ACDF, or an artificial disc. We are going to go in there and take these bones that are stuck together and don't move, and by releasing all the scar tissue at the back of the disc, you're going to get some movement back. We may get a degree or 2 of movement. At first, you'll see the bones don't move at all, and then over time, as I'm working with the laser, you'll see that we actually can get movement of the actual bones, like that's more natural. Naturally, there's about 3 degrees of movement between these bones at each disc in the neck. And right now, this patient has 0 degrees of movement at this disc. I can tell. But when we're done, I expect to have a degree or 2. Okay, grabber. A degree of movement doesn't sound like much. And honestly, most people wouldn't even notice it. But the fact that fusion takes away the movement completely, so you get 0, and then artificial discs preserve movement, so an artificial disc would preserve 0 in this case. The Deuk laser disc repair actually gives movement back. And it's the only surgery in the world that does. So we're actually restoring movement while other surgeries remove it. Let me see, I got to get the laser forward. We're going to be using, Luis,
Yes, sir.
whoever's cutting the plastic is leaving this little thing. See it?
Yes, sir. I see it.
Yeah. You guys got to stop doing that.
Can I have the stripper, please?
Lights on. So we have a little plastic sheath around the glass laser fiber, and that plastic sheath has a little tail sticking out. And unfortunately, it's sticking out right where I have to look and see. So we're going to re-strip this wire. We have a sterile stripper, right?
Oh yeah, yeah, yeah.
Did you get the 1 millimeter stripper?
No, not yet, sir.
But you're going to.
Yes, sir. Yes.
Is it ordered?
Yeah, it is, sir.
Okay, good.
Thank you.
So Luis and I have been experimenting a little bit because for the last 16 years I've been using the same laser fiber. It's a 0.5 millimeter laser fiber, and that means the glass itself is 0.5 millimeter. So I've been using that for 16 years and it's worked great, but there's another laser fiber that's actually a little bigger, and not for the cervical spine but for the lumbar. We're able to clean the discs more efficiently with a bigger laser. So we used it last week or the week before for the first time, and it was amazing. It had great results for the lower back. We don't use it in the neck though.
I can see on the.
No
I
worries.
can see it. You know what I'm saying? We need the scope to.
Yeah, that's fine. Any questions from our audience so far?
No, sir.
All right, so we're going back in. Again, we're starting at C4-5. I think we may have stripped the whole glass thing off, right? Because I'm not seeing it. If you look at the end right now, I don't see it. I just see, no.
Okay, can you turn on the light, please?
Yeah, so we're gonna re-strip this again. Sometimes when you strip it, the glass fiber comes off. So we want the glass tip sticking out a little bit. You need more light or are you good?
No, I'm good here.
All right, so let's run the video of what it is we're doing with the Deuk laser disc repair. And this video animation will explain how we go in and repair the tear and the herniated disc.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, we're just getting started here. We are at the back of this disc herniation at C4-5, and I can tell you, looking at this, tremendous amount of scar tissue. That only happens with chronic inflammation. That means inflammation that's been going on for a long time. There's a piece of herniation right there. It's pretty much calcified, meaning it's rock hard. So this injury to the neck is old. It's at least 10 years old in my opinion. And the herniation so far is an older herniation. I can see this. It's like a rock. See all the golden color there? It's all calcium. So, and again, there's no movement. I'm trying to get movement of those bones. Right now at the start there's no movement, but we're gonna, by the end of the case, we're gonna see some movement. You'll see it's about a degree of movement.
From the cabinet? Yeah. Just stand by for now, yes, please. I mean, have it over here, please. Leave it over here just in case.
So some of the things I can do to help my image is to adjust the zoom and adjust the focus. The focus is not bad. Unfortunately, fiber optic scopes are not as good as rod lens. You can see there's a bit of herniation right there, just sitting on top of the spinal cord. There's the spinal cord down there. We're going to stay away from the spinal cord. Very careful not to injure it. You can see, you see the white color there? Dr. Berndes? You see it right here, right there? That's probably dura over the cord. So we're back in the disc all the way on top of the spinal cord. You can see this stuff from the herniation is literally just squashing the spinal cord. So my job is going to be to remove it as much as we can safely. Any questions, Kev?
No, sir.
All right. He does a lot of computer work. All right. You know, the reality is everybody that has a herniated disc has an annular tear first. And the annular tear is, I don't think you connected, Luis. You didn't engage. Yeah, it's, it has to be, it's not moving. Normally it moves the tube.
Correct.
So we're not engaged for some reason. Let me see. No, it's not moving it.
You want to grab the scope?
No, let me just see. Normally we have this issue with lumbar, not cervical. All right, let me take the scope out. Light on, scope off. Huh. Can you see that? Do you have a dilator?
Yes, sir.
Yeah, this is not engaging it. Interesting.
Do me a favor, can you open that one, please? Open that one, yes.
So the fluid adapter is not engaging the tube. That's our problem. All right, let me see what I can do. And then we may need the dilator and like a coker or something,
Yes, sir. Yes, sir.
so I can manipulate it. All right, let's see what we can do here. All right, so yeah, we're gonna need to bring the fluoro in. Let's bring the fluoro in, and let's get the dilator. We're gonna have to change out the tube. Yep, let's get this fluoro in. And watch the dilator. So the top of the tube appears to be not able to engage with the fluid adapter, so I can't move it and bring it back and move it side to side. It requires a twisting motion, which I'm not able to do. I need a lateral view. So what I'm going to do is bring the dilator back down and basically change out the tube over it, hopefully. That's our plan.
You want to continue with the same scope?
Scope's fine.
Okay.
Is that it right there? Mallet? Shot, I need an inline traction. Get rid of this. I need to get my hand in here. Shot. All right, so I can see the tube is in the back of the disc. Bring this down. Shot. All right, good. Now we've got to get the, we've got to get this tube out. Disconnect the suction. Can you? Yep. Just gently, carefully. Leave it. Shot. Okay. All right, now I got to try to bring this tube out. You have anything? It's just not grabbing it. That's the problem. You have anything I could use
Well, we can use
to
the
bring
ball
it up?
with the towel.
Raytech maybe,
Right there.
or towel. Which do you think is better? Here. Let's see if we can. We're probably gonna. It's probably too thick. Let's see if we can. You have to hold the guide wire. I mean the dilator.
Yes, sir.
Actually, am I moving the tube at all?
I don't see it. No.
Because the next step would be
How about if you remove? So this is not grabbing the. So you
correct.
Can pull, you can pull like you know what I'm saying? Maybe you wanna hammer a little bit over.
Hammer what?
Like if you put the cooker over here.
Mm-hmm.
Yeah. And then hold this.
Let me see. Let me see.
You know what I'm saying?
Yeah, I want to see if it's coming out. Shot. Just the. Hold on. I need a pull. I need a pull. I need you to stay in line just until we're done here. Just don't stop pulling. Pull. Shot. All right. Let's try. Go ahead. Shot. Something's moving. It's not that. Try again. Shot. All right, so the tube doesn't want to back out. We need, huh? No, no. No, we can do that, but it's just slipping. That's the problem. So we're troubleshooting an issue with the.
Well, can we try this one? Maybe this one is different and then grab it.
I think the problem is with the top of the tube, but we can certainly try it. It's not a bad idea to try it. Go ahead.
Yep.
It's working?
Yep. If you want to leave that one, look, that's perfect. Right on.
Yeah, you're right. Good job, Luis. So we need to test that. That may be defective or broken, and we need to get rid of it. All right, so that's our shot right now. All right, so let me just think for a second. We brought this back a little bit, so let's put it back. Yeah, keep the inline traction until I'm done. Let me advance it. Nobody move. We got pulls on the shoulders and the head. Shot. That looks pretty good, but we can do a little better shot. Shot. That's pretty good right there. I'm happy with that. I'm going to be pulling it back a little bit anyway. That's good. All right. You can relax. Back to the task at hand. So the fluid adapter, this little metal piece here, was not engaging the tube, and we needed to be able to move the tube in the disc. So I thought the tube was, I thought the problem was at the top of the tube, but we tried a different fluid adapter. It seems to be working better for now. So All right. Let's get the scope is on. Get the irrigation on. And the light off, I guess. Back down the rabbit hole. Remember, we're still at C4-5. We still have a few other discs to do. All right, there it is. We're at the bottom of the disc there. That's the spinal cord. Yeah. It's not moving it for some reason. It's just not engaging it. I think it is the tube. You know, to be honest with you. I mean, I think it is the tube. Yeah. All right, well, we thought we figured it out. I think it is the tube. So let's
Lights on, please.
get the lights on, scope back in. But this is surgery, you know, this is how it is. Unfortunately, sometimes you run into issues and you deal with it. You're going to need to get more of these tubes.
Yes, sir. Yes, sir.
Come on, come on. Come on, you got to hurry up, Jordan. You got to move faster than that. We're all waiting for you. Let's get a shoulder pull, head pull shot. That's it right there. Mallet. Shot. There we go. All right, now I got to get this tube off. And it's gripping the, let's get a guide wire. Shot. Mm-hmm. Yep. So shot, I've got some options now. I've got my guide wire in, so if I take the dilator and the shot, if I take both out, we're okay. Shot. You're giving me a pull? Shot, come on. Every time I look up, Jordan, I need a shot. Shot. Oh, good. Maybe we can keep the dilator after all. Shot. Okay, good. Almost there. We're there. Everyone can relax a little bit. Hold on, hold on. Shot. All right, good. So coming out, take the guide wire. Guide wire. Take this tube. Let's inspect the top of it.
Yes, sir.
Is there an issue? Yes?
Like this one right here, yes.
Let's get another one. All right, so once again, we're doing the whole surgery through this tube, but it has a crown. And the crown can sometimes get damaged, in which case you need to order more of these, by the way. Do they have them?
Yes, sir.
That's something they have, right?
Yes.
We need to have more of these just in case we get into this situation. Shot. All right, impactor. So we're going to place a new endoscopic tubular dilator, tubular channel, and we're going to advance it like we did before. I need pull with inline traction. I think the better inline we get, the easier it goes without as much force. But like I said, it's a scar tissue that was the problem, and we had to really force it last time because of that. Shot. And I think that may have caused damage to those little crown. What are those projections on the crowns called? Any idea? Maybe tines, spokes, spicules. All right, that's better.
Spindles.
I think we're good now. You can relax. Hopefully this is going to engage properly, and it feels like it has. So we're back to doing what we need to do.
Shot 4.
We knew this wouldn't be an easy one going into it, so you can see the back of the disc, spinal cord down there. All right, back on laser and proceeding. So this is all part of the herniation right here that I'm zapping away. And the herniation is literally stuck inside and scarred up. That's good, don't move it. This herniation is stuck at the back of the disc, right above the spinal cord and nerves. See all the scar tissue and how golden it is? Golden means calcium. And the only time you get calcium deposits in scar tissue is when it's been there for a long time. We call it dystrophic calcification. Doesn't happen overnight. Just starting to get a little bit of movement now. You see that? Not even a full degree. Maybe a quarter or half a degree. And now I'm going to work the other direction. And we're literally between the bones. They're called vertebrae or vertebral bodies, and these are the end plates. So at 9 o'clock is the C5 end plate, and at 3 o'clock is the C4 end plate. And I'm just removing about a half a millimeter of herniated disc each time. Just a little bit at a time, working my way down. Tremendous scar tissue from the chronic inflammation. And it's just a matter of going back and forth. So this is going to take some time to do this. I need to manipulate the tube and get a little bit more lateral towards the foramen. This patient's worst herniation is C5-6. And that's maybe the next one we're going to do. So unfortunately, when you let the herniation go this long, it just creates so much collateral damage in that disc. Back. And again, I'm going side to side and literally gaining small amount of, it's like fighting a battle or a war with your opponent. You battle one direction, and then you shift up your strategy, you gain a little bit of ground, and then you go back the other direction. So we're just slowly making progress here. And the reason why it's so slow, again, is because the significant amount of old injury to the disc that's been around for a long time. And I'm going in here and trying to remove that with the laser, and it just takes time. There's no way you can speed it up. You have to be patient and just get it done. See the blue stuff? That's newer herniation. So we got old and new. And like almost every herniation in the world, it's a combination of old and new. Herniations don't just happen at one time and then that's it. Most people that get a herniation, they feel the symptoms, the pain, they kind of take it easy, and then they get better. And they think, okay, now I'm better, so whatever's wrong is healed. But it really doesn't heal properly. The only way to get it to heal properly is to actually go in and do what we're doing now. See that tear? The white and then the blue in the middle? The blue is the herniation. So the white is the annulus. So far, so good. Had a little hiccup with the tube. Fixed that. Showed you how we did that. Now we're just... And I really think probably this newer stuff is what's causing most of his symptoms currently, because the other stuff looks pretty burned out. Like right here is newer. See the fluffy white and the blue? This is definitely a new herniation right there compared to the old scarred up stuff. So this patient's had multiple herniation upon herniation just at this one disc, because this is all we've seen so far. So you can see old herniation and you can see new herniation. And it's pretty easy to tell the difference. Any questions from our audience?
Yes, we have one from Stantosh from Facebook. He says, how do you avoid injury to the spinal cord with the laser? Is it a type of setting?
Oh, hi Santosh. How do we avoid injury to the spinal cord with the laser? Great question. A lot of people think lasers just shoot out of the glass and then they just go until they hit something. They don't. They only go out about 1/2 millimeter. So look, right now I'm going to hit the laser, but it's not doing anything because the laser beam leaves the glass fiber and goes out about 0.5 millimeters, and then it loses its energy. Why? Because we're inside of a liquid medium. We're using saline, and the saline absorbs the laser energy and dissipates it as heat. And it doesn't actually hit the tissues that are down there. So as long as you're not touching the spinal cord, you're not going to injure it. And that's why it's important to, pay attention and know where you are. I never recommend anyone do this kind of surgery that hasn't had some training and experience. I would recommend primarily a neurosurgeon like myself. We know where the spinal cord is. We know where the nerves are. So the first thing I do is get my orientation. When I get back here is I'll figure out where the end plates are. See, that's an end plate. See how it ends right there, that bone? Past that is going to be where the spinal cord is. That's the epidural space. So I know my anatomical constraints, where they are, and I just stick to, good surgical technique to avoid injuring these delicate structures that are nearby. Great question, though. It's something we have to be worried about, concerned about. This is called annular tear debridement. This is unique to the surgery we do at Deuk Spine. We're the ones who pioneered it. This technique has been peer-reviewed and published as safe and effective for the treatment of herniated discs, like this patient's herniated disc. Okay? So we know that patients that get this kind of surgery, the Deuk laser disc repair, for these kind of disc problems, we know that they do very well, and that we have irrigation. Are we good? And that we can, yeah. Go ahead. Tell me when. Okay, so we'll wait for the bubble. Usually there's a bubble. We know that by doing this surgery, we're able to get rid of about 95% of people's neck pain from the herniated discs, and 95% of their arm symptoms. The arm symptoms are arm weakness, numbness, tingling, pins and needles, that kind of stuff. So arm symptoms and neck pain. We've never studied the effect on myelopathy, which is spinal cord damage. In other words, does this surgery improve people's myelopathic symptoms? We've never looked at that. It's worth looking at someday. But I would have to say it probably does. But if you get the decompression done well, it should. And today we have two very, very difficult cases. This patient, because these herniations are so old and calcified, and then we have another patient later next who I don't think he's agreed to broadcast, but I'm going to talk to him. Oh, he agrees now?
No, he has not agreed.
Oh, he has not agreed to broadcast. So the next patient we're not going to broadcast because the patient... Well, I'll just... No, that's fine. I'm not going to try to convince him. We give people the opportunity to let their surgeries be broadcasted. Of course, we don't disclose any personal identifying information.
This guy actually thought that you had like a cameraman in the room, and I'm like, oh no, that's not how we do it. So,
Yeah, well, we don't have a cameraman.
I'm gonna be like in here with a camera.
Well, we've done that once before. Remember when Diego came in?
I do remember, but
But, yeah.
circumstance.
Yeah, so we don't have a cameraman in the room. We actually have a camera in the room, and our cameraman is
Because he didn't want
Kevin.
to either, because he thought there would be another person. I'm like, oh no, that's not what that was.
Interesting.
Yeah.
Okay.
And he was like, oh yeah, that's fine.
It's amazing because most people that come to me know they've already seen a surgery
Right.
broadcasted live. That's how they find us. That's how they learn about the surgery. So the fact that there are people who come here and have these surgeries that have never watched a surgery on YouTube is quite fascinating to me. So, well, we're making good progress. You can see the blue stuff is the fresher herniations, the more recent, and the scarred up calcified stuff are the older parts of the herniations. So, and as I said before, you know, herniations don't just happen once, they happen many times throughout lifetime, and people will experience pain many times. They get these exacerbations of pain and then remission, and that's the cycle. It's exacerbation and remission. The remission is the body healing, the exacerbation is obviously re-injury. But the problem is, as long as this tear remains at the back of the disc, you're going to have the ability to re-injure the disc over and over again, an infinite amount of times, until it degenerates all the way down, and then you have no disc left to re-injure. So the goal with the surgery is to repair the disc and basically let it heal properly so that it doesn't continue to degenerate and cause degenerative disc disease. The other goal of surgery is to unpinch the nerves and spinal cord, and the other goal of surgery is to get rid of neck pain. You can see the foramen right there through that tear. That's where that dye leaked out, that annular tear. Remember earlier? There's a herniation. So the dye leaked out through that little tear earlier. If you go back and rewind, you'll see it. So that's the foramen on his left, and he does have some left-sided findings, but you can see it's pretty clean. And then we're going to go over to the right side once again and take a look over there. But you can also appreciate that movement is starting to be restored between those bones. So our goals are debride the annular tear so it heals properly, get rid of the arm symptoms, get rid of the neck pain, get rid of the headaches from the neck, from a herniated disc, called discogenic headache, cervicogenic headaches. All right. This is just a giant wad of scar tissue right here and herniated disc. Incredibly big. It's on the right side. So this is where the patient's weakness is, primarily the right arm. Little bleeding from the end plate, no big deal. It's minimal to nothing. Generally, our bleeding for these surgeries is about 1 milliliter Compare that to more invasive spine surgeries where they lose anywhere from 100 to 1,000 milliliters. So we're losing 1% of the amount of blood of traditional spine surgeries. So a lot less blood loss, which is better for the patient. There'll be no fusion. So the Deuk laser disc repair you're watching is a non-fusion surgery. It's a more advanced type surgery. Since we're leaving the disc here, not the herniated disc, but the actual disc, since we're not taking the disc out, there's no need to do a fusion or an artificial disc. We're leaving the patient's natural disc. And by leaving the natural disc, the patient doesn't need anything put in their spine to replace the disc since we're not taking it out. All we're treating is the herniation. So by just removing the herniated part and the annular debridement, you don't need to put support structures back into the disc space. Plus, what a great view, huh? I mean, if you ever watch an ACDF, if you watch my ACDF, you can see everything because we use a microscope, a special microscope, but most surgeons don't. And they literally just go in there and they can't see what they're doing back in the back of the disc. They're just kind of blindly scraping away, which is why so many people have spine surgery and still have problems, because the surgeon can't see what they're doing. And you know, blind surgery is not good for patients, period. But it's done all the time. There are parts of the surgery that are done blind with ACDF, unless you have a really good microscope. Now, we do have the best microscopes available in the world for spine surgery. All right, just about, this was a really bad one. A lot of herniation, a lot of scar tissue. You can kind of see how the little hernia disc fragments kind of peel up away because they're not really supposed to be there. They know that. And once we identify them and isolate them, then they know there's only one place to go. They need to go away. So they start to pack up and leave. Those herniations are literally in the foramen, and we're just debulking them. Beautiful. Starting to see the foramen open right there. That little black cave. Pretty cool, huh? And look at the movement we're getting, right, of the vertebrae. Starting to get movement. You see that? That wasn't there before. So this whole Deuk laser disc repair, we do the opposite of fusing. We give you movement back. It's the only surgery in the world that does. If you look up artificial discs, they preserve movement, meaning they don't give you anything back, but they keep what you've got. And the Deuk laser disc repair is the only surgery that actually gives you back movement. So I'll be done in a few minutes here, 1 minute, and we'll move on to the next disc.
I have a question from Rick from Facebook.
Yes, Rick from Facebook, I'll take your question.
I was told that the stand-up MRI image is not as good as the standard MRI image. Is this true?
It is true. So the question from Rick on Facebook is, I was told the stand-up MRI image is not as good as the regular MRI. And the answer is typically yes. The quality of an MRI image depends on several factors. One of them is the magnet itself. The other is the coils. And the other is the technician who's doing it. And the other is how much time you spend in the magnet. So the longer you're in the magnet for your study, the more detailed MRI pictures you're going to get, the clearer picture. But the problem is most MRI centers, they want to maximize their revenue and profit, so they basically will put you in and for a short sequence because they just kind of get a blurry picture, because that's faster, and they can see, they can do 20 patients a day rather than 10. So they can make more money and pay their overhead. That's unfortunately where it's gotten to, because insurance companies keep cutting what they pay MRI centers for MRIs. In the old days, an MRI paid $1,200, $1,200. Now, MRI get paid around $400. So they've seen a 60% decline in payment, yet the cost of MRI scanners is the same. It's over $1 million. And the everything, all your overhead's the same. So what I'm getting at is, in an effort to make things meet, make ends meet, a lot of the MRI scanners cut corners. And one of the biggest corner cutting is done through shaving time in the scanner. So you get poor quality images. But with a stand-up MRI, that's not the case, obviously. But the problem with the stand-up MRIs is the coil, and the coils aren't as good, and the let me think for a second. I'm just trying to figure out what to do with this foramen. The quality of the magnet is not as good. So you've got issues mostly with the coil. And it's nothing, but nothing that you can do about it. It's just an inherent limitation of that machine. So, but some people like it because it shows bulging disc better, and I think it's not a bad idea. But yeah, there's definitely a limitation on quality of image in terms of resolution. But you do have the benefit of having a stand-up study, which can show more. Just about done here. That foramen is open and empty. I can't get anything else out of there. So I'm pretty happy with that. I want to see if I want to come down on the top a little more. Right here. Really taking my equipment to the maximum limit. Great question.
He had another question. I'm allergic to any contrast dye.
Just a little bit too low. I'd bring your volume up 5%.
He has another question. He's allergic to any contrast dye. Do I really need the injection for thoracic MRI?
For what kind of MRI?
Thoracic.
I couldn't hear what you said.
Do I really need
thoracic?
thoracic MRIs?
No, I don't think you do need the dye unless you have a tumor. If they suspect a tumor, or if they suspect multiple sclerosis, an inflammatory disease in your thoracic, then you need the dye. Oh, look at that herniation that just came out of the foramen. That's so cool. So if you're just dealing with thoracic pain and you're looking for a herniated disc, then you definitely don't need the dye. I don't order the dye. But if your doctor is looking for a tumor or an infection or inflammation, then you should get the dye. All right, we're done here.
Scope out, please. Lights on, please.
Dilator. So we're done at C4-5. It went well. Yeah, we're just going to put a little antiseptic. So we always use a little antiseptic not because we have an infection, we just want to make sure patients don't get any. We don't have any bacteria contaminating the field, but it's always good just to do a little antibiotic irrigation. We use betadine developed at NASA. It's very safe, as long as patients don't have an iodine allergy. Here, which we always check for. All right, at this point, get the fluoro in. So we're done with the one disc. We're going to move on to another disc at this moment. We're going to need a little shoulder pull, a little inline traction, get all our cables managed, and then we're going to slide along the front of the spine to the next disc. My intention is to do C5-6. Go south one disc. Great questions from the audience so far. All right, let me know when you're ready there, Jordan. You got to tell me. Ready. Okay, then we need a inline traction on the head with slight extension. I need a slight shoulder pull, not yet, Luis, but let me see. Move your hand. Take your time, take your time. All right, let's get a shot. Beautiful. Beautiful. All right, everybody stay where you are. I'm going to remove this tube, leaving the dilator. And then I'm going to just don't want to get, it's too close to him. He's not sterile. Yeah, but still that stuff isn't sterile there, so the best thing to do is to keep that higher normally. All right, so let's see where we are. All right, beautiful, beautiful. I like it. Okay, so everyone get in their positions, and I'm going to come out of 4-5 and walk my way down to 5-6. Just relax, Luis. Hold on, hold on. We got a lot of fluid there, but I don't think it's interfering. All right, shot. Great, so we're coming out. Gonna get onto the top of the spine. Everyone do your job. Shot, we're just about there. All right. Let's get an AP. Relax just for a second. Don't move too much, just relax. Remember, the inline traction is with extension, not flexion, whatever you do. Shot. It's a quick shot, Jordan. It's not a line up beautifully shot. All right, lateral. Yeah, it looks good. We're pretty much right in the midline, just a little bit to the right. Sorry, to the patient's left, my right. Yep. All right, shot. Okay, good. Shot. Let's go back for an AP. Coker. Feel like, let's get a real AP. So we're a little bit off to my side. Okay, back to a lateral. Wait, stay there with the AP for a second. See if I can get us back to the midline. Feels like a bone spur. Stay there. Yeah, it's slipping. Shot. All right, that's better. Lateral. There's a piece of herniated disc. And shot. All right, I need us to pull the shoulders, pull the neck. Coming south. And maybe what I'll do, if I'm not, we can't be moving things around. It's just in line and hold it. Can't have you moving the head. Changes everything. All right, I'm going to try to walk my way down. If I can't do 5-6 safely, then I'm going to have to do shot 3-4, just about there. I'm right on the herniation. There it is. All right, shot. So let's get an AP and see where we are. Nobody move. All right, not bad. Stay there. I'm going to move it a little bit more. Shot. It's good. Lateral. Mallet. Have it ready. Not yet. Just have it ready. That looks pretty good. Shot. Let's get an AP. Coker. So I'm pretty much anchored in the ALL. Shot. Perfect. Lateral. And I need a good lateral, guys, at this point. Now to me, Luis, I need you to give me a good pull. I need inline like this. Not like this, like this. Slight extension. AP looks perfect. Lateral looks good. I just got to angle it. Shot. Yes. Everyone stay where you are. Let me have a pipe cleaner. We're going to just push any disc material that's gone in the tip back out. So we can do a little discogram shot. I can't really tell shot. Let's try. See what we can do here. Yeah. All right, I think we got it. AP, Coker. So we've moved to the 2, 3, 4, 5, 6. I'm sorry? Shot. That's our ray tech there. It looks like there's a little bit of dye in there. All right, that should be good. So let's take a look. Back to a lateral. I'm going to have to advance this. Shot. Very nice, guys and gals. Shot. Almost done. Shot. Shot. That's it. Good. Relax for a minute and we'll pick up again in a second. All right, so we have positioned the dilator right where I want it on the lateral view. You can see the tip. Show them the tip. The tip of the dilator is at the back of the disc, exactly right where the herniation at this level is. And this is an important level because this is where the worst herniation is. And I can tell you this dilator went in easier. So 2, 3, 4, 5, 6. All right. Yeah, but I need the impactor. So now I'm bringing the tube down. And just so everybody understands, we're doing this whole surgery through a 4mm tube. And the advantage of that for the patient is minimally invasive. Shot. This is the most minimally invasive spine surgery in the world for disc problems. You can't get less invasive than 4mm. And if you do, it's not really a surgery. All right, guys and gals, we're going to need to do a shoulder pull, head pull, inline traction, please. We need a good, I feel it good. Shot. Let's see where we are. Perfect. Alrighty then. Shot. Can you do any better than that, Jordan? I'm having a hard time seeing the dilator. Can we clean that up a little bit? All right. That's probably as good as we're going to get. Let's watch the dilator, everybody, and make sure it's not advancing. Shot. All right. I see the tip of the dilator is literally at the back of the disc. I'm going to keep advancing. Shot. Shot. The tube is going in. Shot. Shot. So, nice pull, right? Yep, shot. Perfect. Absolutely perfect. Let's bring the dilator back just a smidgen. Take that. And I don't want to bring it back too far. I just want to make sure we're not going in too far shot. All right, so that got worse. We need a better picture. Luis, give me a good shoulder.
Yes, sir. Are you ready? You're good?
And everybody pull, shot. There we go. Shot. Boy, what is that? Okay. It looks like there's something with contrast, like some liquid. Shot. Just about there. Shot. I think that does it. Yep. All right, we're good. Great job, everyone. I know that was tough. I apologize. Take your time, Luis. So at this point, we've brought the tube in, and I'll show you the tube that we're using.
What do you need, sir?
The old tube. Where's the old tube?
Crystal, can you check my
Can you see this, Kevin?
in the bag? I couldn't bring.
Yeah, so the whole
Yes, sir.
surgery, you see this, Kevin?
Yes, sir.
The whole surgery is being done through this little metal tubular retractor. This is the smallest, skinniest tubular retractor in spine surgery. And we good? And basically we do the whole surgery through that skinny little 4mm tube. All right, let's get the fluoro out. So this of all his discs is the worst one, and I'm glad we're able to get to it. It was really tough. Honestly, this is not a beginner level case for endoscopic spine surgery. Because of the thickness of the neck, because of the broadness of the shoulders, it makes it far harder to reach these bottom discs. And this is the lowest we're going to be able to go. We're not going to be able to do anything below this because of the anatomy of the patient. We're constrained by his anatomy.
Very much. Thank you.
So after we're done here, we're going to go up to 3-4. And, you know, you have to know, as a good surgeon, you got to know your limitations with patients in terms of what you can and can't do. Now, the limitation on this type of surgery with the neck, it's very hard to know unless you're in the operating room. As a matter of fact, it's almost impossible. Being in the operating room changes everything because you're able to intubate the patient and relax them so that all the muscles in their neck relax. And what happens then is that you can actually get further than you can without the relaxed muscles. You can pull the shoulders down and get a little bit further, maybe another ½ inch, either direction. So, but in the end, cervical laser surgeries are going to be limited by the patient's anatomy. The thickness of the neck, the length of the neck, the bigness of the shoulders, thickness of the shoulders. Now this herniation looks newer. This is more recent, definitely. Not as bad so far as that one we saw last time at 4-5. 4-5 was much older. There's still some chunky pieces here that are collagenized. I call them collagenized. And that's a term I've taken from Dr. Anthony Young, one of my teachers in endoscopic spine surgery. Dr. Young recognized early on that some of the disc fragments are thicker and have a lot more collagen in them because they've been worked over by the inflammatory system. So we call them collagenized. And I see a lot of that. The older the herniation, the more scar tissue that's forming from chronic inflammation, the more collagenized. All right. So we're at the back of 5-6. And we need to get our... Everything okay, guys? No worries. Well, it's supposed to be cold. I thought you liked dressing up like Darth Vader, though. All right. So far, everything's going well for our patient. For those of you that joined late, we're doing what's called a Deuk laser disc repair. Deuk laser disc repair is endoscopic spine surgery done to treat symptomatic herniated discs. And what a lot of people don't understand is that bulging discs are herniated discs. So there's 3 types of discs injuries. The very beginning is called the bulging disc. That's where you have an annular tear. Thank you. That's where you have an annular tear, a tear in the wall at the back of the disc. And then you have a herniated disc where the tear is penetrated by a large amount of nuclear material, like this stuff right here that we're blasting with the laser. And then, of course, over time, the herniated disc becomes a degenerated disc. So everything starts with the annular tear and the bulging disc, which becomes a herniated disc. And of course, a bulging disc is actually a herniated disc. But for some reason, people like to call it a bulging disc. It's just a small herniated disc, but it's still a herniated disc. The golden color always represents calcium, metal, interacting with the laser. The laser energy causes it to oxidize. So you actually get a sudden change in the coloration of metal. And when you see that, you know that tissue has a lot of metal, which is quite interesting because normally the metal in pathological tissue of humans is only seen microscopically, and it was recognized by pathologists using microscopes years ago. They call it dystrophic calcification. And it's if you look it up, it's a process that occurs in damaged tissues quite frequently. Lots of herniations here. These are all fragments of herniated disc. They've all exited and gone into the epidural space at one point or another. Here's the annular tear. We're cleaning up the edges. Any questions? Another piece of herniation?
No,
right
sir.
there? Now look at the difference. See how those chunks just come out? Like you kind of release them with the laser and then they pop out. And remember the other disc, it was so scarred down, they didn't pop out so nicely. That's because the other disc we did was much older herniation. Oh yeah, there's another herniation right there. Awesome. We're going to go grab that one with the grabber. Let's see how big this guy is. Anybody watching the Olympics? Curling. Uh-huh. Has anyone seen this Russian ice skater, female? Supposed to be the top female ice skater ever in the history of ice skating. She scored a 90, and no female has ever gone over a 90. And she just did a what's called a quad turn. First female in Olympic history to ever do a quad. Other women have tried, but she actually completed 2 of them in her program yesterday. She's 15 years old. All right. Very impressive young lady. Well, we got just a bag full of herniations here. Herniations galore. Trying to grab it out, but I can't because it's too big. Literally too big to pull out. So I have to work on it. You can see these are all herniation right here. That's the annular tear you're seeing, and the blue, the faint blue color is the nucleus pulposus. We're literally looking at the back of this disc right here. Herniation right there. I told you this one has the most herniation, by the way. And so I feel so far really good about it. But it's all stuck down. Look at that right there. There's a piece of herniation. Bam. We just freed it up with the laser. And then I try to float it out because I don't want to put the grabbers in. There's so many pieces. Yeah, and every disc is different. It has its own personality. Every disc herniation. Some herniations there's a lot. Others there's not so much. Some are more scarred up and others are less. This is a combination of both. You can see oh, there's another piece, just a big, there's so many here. Amazing. How many pieces have we taken out so far? It's got to be over 10. Yeah. And they just keep coming. We've just started here. So this is a lot worse than I thought it would be based on the MRI. So, but you know, the truth is over the years you learn not to really rely on the MRI entirely. You need to just figure out which discs are the source of pain and then get in there and treat them. And a lot of times you'll be surprised at how much herniation is actually there. It's more than you think. It's usually more than you think it'll be based on the MRI. Rarely is it less. As a matter of fact, there's a concept called internal disc disruption, IDD, and it's an older condition that not all doctors understood, but I think it's true. I wasn't the first person to discover it. And what it means is that the disc is like blown out on the inside, really badly damaged the inside, like a grenade went off and just destroyed so much of the disc, right? But you don't see it on the MRI because the MRI doesn't really show that internal architecture of the disc. It just shows the big disc and that's it. But it doesn't show just how fragmented the disc really is. So internal disc disruption has been postulated to be something that is real, and I found it to be real with my endoscopic surgery. But it's also believed to be a source of pain, disc pain for patients, and I found that to be the case as well. But of course the pain itself is coming from the annular tear, not the actual internal disruption. But the internal disruption and the annular tear coexist. And of course, because the internal disruption creates inflammation within the annular tear, you get all this swelling and pressure of the actual disc on the annulus. Turn. And that causes the pain that people experience. So it's real. I've seen it, treated it many times, and a lot of doctors just don't believe it. These are all pieces of herniation. Every one of them you see floating up. So many. They say it looks like crab meat. Kind of does, right? Feel like I'm in Baltimore, Maryland. Anyway, I know this patient has some family members that are supporting him. Maybe they've had an opportunity to come in and watch a little bit, hopefully. But if you do, the surgery is going very well so far. No problems. Just a lot of work. Still a lot to be done. We're about halfway done with the surgery part. Any other questions?
No, sir.
All right, well, for those of you who don't know, Duke Spine Institute does have an app. Our app is free to the public. It's educational. It has a lot of good resources if you're having back or neck problems, spine problems, herniated disc, bulging disc, spinal stenosis. There's a library in there where you can learn a lot about these conditions. And like I said, it's free. You could also link up to our live streams through the app. And you can do an MRI review through the app. I think it links to our website. So you can take advantage of it. So one thing we don't talk about very often, I think is worth talking about, is how do these patients do post-op, and what are some of the other things that can happen to people post-op? Well, obviously there are complications that can happen, but we've not had any, fortunately, with this surgery on the neck. And we have patients, though, that will occasionally have pain coming from something else. Remember, your neck, your spine has lots of pain sources. The discs are just one of the sources of pain, and the most common. But after the disc, there's facet joints, and facet joints are a very common source of chronic neck pain. Facet joints require treatment of the facet joint. Specifically, they require a procedure called a rhizotomy. And that can be done through different means. One of the means is radio frequency ablation. I don't know if I got it. Another way to do it is, was I this way or the other way? Another way to do a rhizotomy is with the laser, endoscopically. We've started doing more of those endoscopic rhizotomies in the last few months, and we've had really good success with it. So typically what we'll do is we'll confirm the diagnosis with a medial branch block, and then we will perform a needle radiofrequency ablation, which is the typical way of doing it. If that gives the patient good relief, but it doesn't last, then we'll come back and do the endoscopic rhizotomy. But when we published our paper originally on this surgery, I made note that a large number of patients, a pretty good big percentage of them, have cervical facet syndrome afterwards. And that's pain in the facet joints. So of course it's different than disc problems, disc pain, because the facet joints are on the side of the spine, so the pain is more lateralized to the side. And it doesn't cause pinched nerves like a herniated disc does. But just the fact that there's this new technology available now to treat facet pain is, and it's very, very good at it, is great news for people that have facet pain. Because the only other way to fix it, unfortunately, is fusion of the spine. And people want to avoid that. You can see all the little pieces coming out. Once again, we know this is a pretty big blowout of a herniation. There's another piece of herniation. We've gotten, I would imagine, most of the herniation at this point. People ask me as well, when you're in there with the laser zapping away at all these pieces of disc, I mean, are you leaving any of the normal disc there? And the answer is, of course, we're actually not removing any of the normal disc. We're only removing the herniation, and we're cleaning the tear. And the tear is definitely not normal either. It's completely scarred up. So all right, we're getting there. Come on now.
Arun from Facebook has a question.
How's our irrigation? All right. Sorry, who?
His name is Arun from Facebook.
Arun. Nice to meet you.
Are there any studies on reoccurrence of disc issues post-surgery?
Are there any studies on reoccurrence of disc issues post-surgery? There are. For the Deuk laser disc repair, it's 1%. So 1 out of 100 of our patients will re-herniate. Generally, as long as you follow the instructions, it's not going to happen. But I've had a couple of patients who say they followed it, and it still happened. The biggest one that will happen is at nighttime when you're sleeping, tossing and turning. If you have a cervical Deuk laser disc repair, you can actually re-herniate at night. So I actually tell all my patients to wear their collar at night as well, because of the risk of re-herniation. Now, what's the risk of herniation after surgery for fusion, artificial discs? It's actually much higher. It's probably around 5% reported in the literature with good surgeons. And with average surgeons, it's probably higher than that. It's probably closer to 10 or 20%. I've seen some surgeons report re-herniation rates with artificial disc and fusion, ACDF, as high as 20% of patients. That's 1 out of every 5 is going to need another surgery. It's usually at the adjacent segment, so not at the index level, the third level they treated, but at the next level, above or below, or both. So yeah, it does happen. Still, the Deuk laser disc repair, the surgery you're watching now, has the best rate. All right, we're at the back of the disc. These are actually the fibers of the posterior ligament, the PLL. And you can see they're still scarred up pretty bad, but I've gotten rid of all the herniation back there. A little bit of scar tissue and herniation here, which I'm going to take care of. But that area back there in the center is pretty much gone. This is what herniations do. They literally cause tremendous inflammation because they irritate the heck out of your body. That nuclear material is not supposed to be sticking out. It's like a prisoner, the worst prisoner. All right, who's the worst prisoner? Let's pick the worst prisoner. I'm being generic here, okay? But everybody gets a vote. I want to hear. Worst prisoner. Dennis who? BTK? Yeah. All right, Dennis Rader, BTK. Worst person. Worst, like most destructive. Huh? Hitler. Who? Hitler. All right, Hitler. All right, let's leave Hitler out of this, though. All right? This is like Marvel Comics, you know, that kind of person. I don't think so. Let's stay away from real people. Let's just use imaginary. All right, so like, you know, what's that movie called? Birds of Prey. They had another one. Yeah, the crazy girl. Help me out here, Kevin. Yeah, something squad. Suicide Squad. All right. So take your worst criminal in the world, whether Suicide Squad. No. You know, pick it. You know, Juggernaut. What? Joker. Pick your criminal, the worst criminal there is, that does the most damage and destruction. That's what the nucleus pulposus is. It's literally locked in a prison inside the middle of your disc. And then when you get a tear from trauma, like you get into an accident, that causes a tear in the disc wall. And it's like it's like cracking a hole in the jail cell of the worst criminal. They're not just going to sit in jail, they're going to escape. And when they escape, they're going to do damage. And that's what these herniations do. They literally, the nucleus gets out and it does massive damage through inflammation. It's so irritating, so damaging that it causes all this scar tissue. Your body's defense, your body's effort to stop the damage and repair the area just makes more scar tissue. So that's what we're fighting with this disease. We're fighting an evil entity that was, who? Dexter. Fine. It's like letting Dexter out of prison. Okay? And the new Dexter is weird? I haven't watched it. I've been too busy dealing with my teenage kids. Speak about destruction. Right? Holy mac. I don't have any irrigation. Okay. Just about done. I literally need another 30 seconds here and we're done. Then we got one more disc to do. So do you guys understand what I'm saying? Oh, look at that herniation that came out of there. That was like a freaking shard of ice. Ice shards. Now I'm thinking about Thor. Huh? What were those people? The ice giants? Right? You guys never saw Thor? Are you kidding me? You've not seen Thor? What is wrong with you guys? I'm busy and I have time to watch these shows. You gotta watch Thor. Of all movies, of all people here, you would like it. What's the guy's name? Yeah, come on. Yeah, he's a hunky guy. If anything, you should watch it for that. What are you talking about? Or does your husband get jealous? Huh? Listen, my wife is like always watching Brad Pitt. She's like, we're done here. Game of Thrones is nothing. Is there really a lot of exotic scenes, erotic scenes? The Witcher is, yeah. There's a lot in The Witcher. See? You would like The Witcher, I'm telling you. Oh, The Witcher is better than Game of Thrones. All right, we need a poll. We need a poll. Kevin, do you know how to run a poll?
Yes, sir.
We need Game of Thrones versus Witcher. Which is better? All right, we need people's opinions here. We're putting it out for a vote. Game of Thrones versus Witcher. I'm not saying season, just in general. Series. Game of Thrones versus Witcher. Who likes which one more? I know it's a little off topic, but I thought I saw a spine in each at one point. Somebody's spine was showing, so we could relate it. All right, we're done with number 5-6 and number 4-5. So now I've got to make my way up to 3-4. And there's two ways to do it. One is to walk this dilator up. The other is to just pull out and put my finger on and put the needle in and try to start over. So whichever is safest is what I'm going to do. I need to assess the ability to march myself up with the dilator. That's typically what I do. But he does have a thick neck. You'll put him in slight extension and neutral or inline traction. in line with slight. All right, we're going to get our floral position because everything we do during spine surgery is guided through a navigation process using fluoroscopy. Okay? Fluoroscopy is a special x-ray machine. And you guys can't really see it, but it's kind of hidden over here under the drapes, but that's what we have. All right, are we ready? Everyone ready, ready, ready? So let's see what we got. Sean? All right, that's good. So I could see C3-4 up there, and I'm going to pull out the tube. Hey, 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 come on. You know better than that. Nice and slow, Sean. There it is. We're about to come out of the disc, and there it is. And now work our way up. You can see the collar of the tube is outside the disc. And now it's just being held up by soft tissue. So I just got to pull it. Because I really did make the cut 4 millimeters, so it's a tight fit. That's exactly what you want. Look at that beautiful incision, folks. Incredible. You're watching the most advanced spine surgery in the world for herniated discs. And we've lost maybe 5 drops of blood, but we're not done. So I've got to make my way up to the top. So let's just regroup. Do we got a shoulder pull?
Yep.
We got a head in line.
Yep.
And let's see where we are then. Shot? Come on. There we go. All right, so I can see what I need to do. I see the disc, I see the target, and I see how to get there. So here we go. Coming out. Shot. And again, I have a little bit of resistance from the soft tissues. So I want to pop out of that disc, stay on the front of the spine. Shot. Pretty close. About 3 millimeters, and there we are. We're out and we're in front. Now I want to make my way up to the top, but let's just make sure I'm still in the midline. Let's get an AP. Everyone hold. Shot. Still midline, go. Lateral. I like to march up on the lateral view because it gives you an idea of the mountain ranges you've got to go over to get up to the next level. So there we are. And you can see I've got a, what is that? 2, 3, 4, 5. We're about to get to 4, 5. I can feel the mountain range. I just jumped over it. I'm kind of in it right there. So let's go a little bit further. There we go. All right, I can actually feel this, believe it or not. And now we want to get an AP, Coker. So an AP tells me, am I getting off to the side, left or right? You don't want to do that. You need to stay as close to the midline as you. Quick AP, quick. That's it. We're a little bit off to his right, but we're good. Take, lateral, go, go, go. You really need to use lateral as your primary navigational plane. And then when you want to verify you're not off to the side, left or right, oh, come on, man, you got to lock that arc. Pull it down and lock it. I just pushed it down. All right, let's see, 2, 3, 4. All right, so we need to make our way up a little bit higher. Shot. Shot. Right there, I feel it. All right, now I need to make sure I'm in the middle. AP. Everybody hold, we're almost done. So I'm underneath the esophagus right now, literally like, I don't even know how to explain it, but kind of under it. Give me a good AP. So I need to come a little bit to my side. Stay there. Nobody move. Shot. That's pretty good. I like it. Let's see if I can get a little better. See that? Let's see, maybe too much shot. Shot. All right, lateral. I like that. 3-4 is tough to get to, folks. Stay, everybody stay. We're almost done. That's beautiful. Shot. All right, we're in. Like, take it. Shot. Let's give me an AP. Just make sure. And then this is a nice AP. I want a derotated skull with staring straight up and down. Not an easy case, folks. This is one of the harder ones I've done. No. Come on. Give me a good... Spinous process is lined up beautifully. That looks pretty darn good. I got to admit, that looks pretty darn good. All right. Lateral. We're in the midline. And you don't have to be dead center, but you need to be within 5 millimeters on each side of the center. So you got about a centimeter of space. And what you're really doing is you're working between something called the longus colli muscles. And the longus colli muscles run up and down the spine in the front. The longus colli muscles carry the sympathetic trunk inside the belly, just under the fascia. And if you damage the longus colli muscles, you can damage the sympathetic trunk, and you get a Horner syndrome. I don't want that. I don't want a Horner's. Shot. I'm not that kind of guy. So avoid damaging the sympathetic trunk located within the longus colli muscles running up and down the spine. Shot. Beautiful. Look at the tear back there. Shot. AP. Shot AP. Go AP. No, Coker. So I got a nice lateral view. You can see the tear in the back of the disc. As a matter of fact, it's pretty cool because you can see both tears. They look like two waves on top of each other. Oh, I wish you would have shown that. Anyway, you can see the tears at the back of the disc. Big, broad-based annular tear. Dye leaking out on both sides. Worse on the left, as a matter of fact. All right, back to a lateral. We've done our discogram. We've done 3-4. We are going to be able to fix 3-4, 4-5, 5-6. 6-7 is not possible in this patient because of his anatomy being too difficult to get there. But I think we're going to get rid of 95% plus of his symptoms because the bottom disc is the least affected. All right, almost done. You can see I'm passing through the tear. If you've been watching and you rewind, you can see that dilator tip has been moving through the tear at the back of the disc. So I'm literally sitting in the annular tear with the herniation in front of me. Pretty amazing. Now, of course, I didn't come up with this part of the surgery. This was developed by the Koreans, South Koreans. You know, mostly Dr. Seng-Ho Lee and Dr. Gun Choi, who taught me how to do this approach. But now, once I get in there, what I do is mine. You know, the moment I dock this tube at the back of the disc, that's the end of what they taught me and the beginning of what I developed as the Deuk laser disc repair. Shot. Mostly other surgeons that do endoscopic, cervical, or lumbar surgery, they have one goal: get rid of the herniation to unpinch the nerve that causes arm symptoms like pain in the arm, numbness, tingling, and weakness in the arm. Is that my shot? But my goal goes beyond that. With the Deuk laser disc repair, we don't want to just get rid of arm symptoms. We want to get rid of spinal cord symptoms. We want to get rid of headaches. We want to get rid of neck pain. Shot? Everything okay? Guys, gals? Do I need to worry? All right, do we have a little inline, doctor? So as I'm advancing, I feel a little bit of scar tissue here. Are you pulling? Yep. You can see the disc space open up about 0.5 millimeter with that pull. Shot? Beautiful. Tick tock, tick tock. Just a little bit more, guys and gals. Hold on. Let me advance the dilator a little bit. Shot. Oh, it's perfect. Just about done with our placement at the last disc today at C3-4. Shot. That's perfect right there. Everyone relax. Doctor, thank you. I don't know if you noticed it, but by giving me a little inline, you open up the disc space 0.5 millimeter to 1 millimeter. And so it really helps. All of this surgery you're watching is FDA approved. Everything we use is FDA approved. People ask me that, is your surgery FDA approved? Of course. We wouldn't do anything here in the United States. We wouldn't do anything that isn't FDA approved. That doesn't mean other surgeons don't, because they do crazy stuff. They had a story about a guy who went to Home Depot, a surgeon, and bought a rod at Home Depot and put it into somebody's spine. Of course, the rod's not FDA approved, so he got into a lot of trouble, went to jail. I have no desire to go to Club Fed. Personally, I like Club Med.
Lights out, please. Thank you.
But you hear stories sometimes about people doing things they're not supposed to do. You'll never hear one at Deuk Spine about that. We always do everything properly, according to the law. And we have really good results. So these are all little pieces of herniation floating up. Come on now. You can actually see a little bit of redness on there from inflammation. Grab her. Remember, this is an inflammatory condition. A lot of people don't understand that because their doctors don't understand it. Most spine surgeons think herniated discs are a structural problem, compressive, structural, pinching a nerve, pinching the spinal cord, that's it. They don't go beyond that. But the reality is herniated discs cause the vast majority of their symptoms through inflammation. Inflammation. And inflammation is not a structural thing. I mean, you can see some edema, you can see some, visually you can see some granulation tissue, which is very vascular tissue, but inflammatory conditions are generally not structural abnormalities, they're physiological abnormalities, and they cause horrible, horrible problems for people. Everyone with inflammatory condition knows. But what's been underdiagnosed all these years and underrecognized is that herniated discs are an inflammatory condition. Everyone's treated them as a structural condition. But at Deuk Spine Institute, we recognize the inflammatory nature of discs, disc herniation. So now there is certainly epidural steroid injections that pain management doctors do, recognizing the inflammatory nature of the disease. However, you can't stop after an epidural. You have to go on with a treatment to get rid of the inflammatory symptoms. And that treatment is what you're watching today, Deuk laser disc repair. Through debridement, we're able to get rid of the source of inflammation by debriding away the herniated disc that's stuck inside the annular tear. Now this disc, as you can tell so far, is a fresher herniation. There's a little chunk of herniation right there that just came out. Doctor, we need 15 minutes. We'll be done. 15 minutes. And we are not going to be doing 6-7. We cannot reach it safely. So please make note of that. Hello? Can you make note of that?
Yes, sir.
6-7, we cannot, due to patients' anatomical restrictions. There's a herniation. And as I said earlier, the good news is 6-7 is the least affected, and I think he's not going to have much symptoms from that disc. There's the tear right there. Cleaning it with a laser. All right, there's another herniation that came out of the foramen behind the tear. Any questions for me? Is our next patient here? So once again, our next patient does not want this surgery broadcasted. We of course ask all of our patients permission to broadcast. This next patient refused, which is their right to do so. We respect that. We will not be broadcasting the next surgery. So I think you all should go have lunch while we're gone and then come back for the last surgery. What is our last surgery today? A lumbar Deuk laser disc repair. Excellent. Huh? A 3-level lumbar. Excellent. So our last surgery for today will be a lower back, patient with lower back pain and leg pain. And we're going to treat three levels of herniation, right? L3-4, L4-5, L5-S1, I believe, unless we're doing a bilateral. And this patient has, by the way, that's the foramen right there. Look at the neuroforamen. It's pretty cool, huh? So we saw some big chunks of herniation coming out of there a minute ago. If you rewind, you'll see them. But I've just opened it up and looked in there, and there's nothing in there anymore, nothing pinching that nerve. So I'm pretty happy with that. I'm just cleaning up the edges of the annulus so it can heal, getting rid of all the blue stuff, the nuclear material that's keeping it from healing. A little bit there, stuck down.
Can you give the muscle reversal agent?
Yeah. Yep. That's so cool, huh? Looking down the foramen in there. One of the things about the laser that a lot of people don't understand, it doesn't do all of its work just through laser energy. It actually also creates a cavitational wave in the fluid that is very powerful. It's like a power washer, you know? And that's part of what I do. I power wash the back of the disc to remove any loose pieces of herniation. So the laser energy releases the herniation, and the power washer, the pulse, blasts that fragments out so we can suck them out of here, get rid of them. Pretty cool, huh? There's an example of the power washing effect right there. All right, any questions? So the question is, does the nucleus material regenerate? The answer is no. What nucleus material you're given at birth is what you carry, actually at some point when you stop developing it. I don't know if it's at birth, but it's probably around the time of birth. So certainly in utero, you're born with this fixed amount of nuclear material, and that stuff doesn't rejuvenate or reaccumulate, reconstitute. Once it's gone, it's gone. Now there have been people trying to put new nuclear material back in the disc, and every time they try, it pops out after a while. So nobody has been successful at putting nuclear material, but you don't need to, okay? The fact that everybody I treat, their pain goes away and their symptoms go away, you don't need, and I don't put nuclear material, what does that tell you? It tells you they don't need it, right? You're just gilding the lily. And you don't want to gild the lily because the lily is beautiful enough as it is. You don't need to try to make it more beautiful. Appreciate it for what it is. Anybody know what animal, or not animal, but what life form on Earth has the most genetic material? What living organism has the most genetic material? Just raw genetic material, like DNA. Nobody? The lily. Yeah. I was surprised to find out that a plant has more DNA than an animal. But it's not about how much DNA you have, it's about how you use it. Right? Elephant has less genetic material than a lily, but it certainly is bigger because that genetic material codes for more proteins and more fat. Just about done, but we just got a few more minutes to go here. So, have you done a poll for The Witcher versus Game of Thrones?
Yes, sir. We only got one answer from Sherry, and she said she likes neither of them.
She likes neither. There you have it. They're both horrible programs that nobody likes. Okay? The problem with scientific research is that when you have scientists that don't know what they're doing and they ask questions and they don't conduct the study properly, you get answers that really are meaningless, but they try to apply those answers to real. Of course, that's the problem. Our sample size is too small. Okay? So we can't make any kind of conclusions about. Well, there you go. That's your homework for tonight, right? Okay. So do you need our help? Should we set this out to a poll? You don't want to poll the community? I'm pretty disappointed that we don't have more answers than that. All right, well, let's poll our operating room then. Fine. Game of Thrones, say aye. Come on, guys. How many ayes? It's Game of Thrones. You what? Yeah, but what about The Witcher?
Yeah, no, I like The Witcher.
Okay, so, all right, how many for The Witcher then?
I think I'm going to.
Luis is a Witcher, I'm a Witcher. Who else is a Witcher? I see Jordan. Who hasn't voted? Dr. Bernadette. Come on now. Cast your vote. You haven't seen either? All right. You can abstain. You said Game of Thrones? All right, so how many Game of Thrones is that? 2? Versus 3 Witchers? No, Jordan is a Witcher. Uh-huh. Luis, we won. We're good. We're good. And for those of you who said Game of Thrones, no lunch today. Sorry. I'm buying lunch for the Witcher fans. And those who abstain. Just kidding. Just kidding, guys. Take it easy. There's going to be a mutiny in here.
Lorraine from Facebook says Witcher as well.
All right. Oh, good. So there we go. Thank you for voting. Yeah, 1 level. We're pretty much done here. I'm done. Great job.
Yes, yes.
Everyone, great job. I want to show everybody watching. This is the surgery. I mean, we did it all through one little cut. Okay? Don't expect to be able to find surgeons where you live that do this. there are not many of us in the world, literally probably a handful, that can do anterior cervical endoscopic through a 4mm incision. And what that means is we need more doctors trained to do it, because obviously we're not going to put a metal plate in here. There's no metal needed. There's no cadaver bone. It's all natural. That's one of the nice things about this particular surgery, is that it's all natural. So no metal, no fusion, no artificial disc, no nothing. Just go in and fix the herniation through the disc. This is a transdiscal procedure. All right, we're going to take this out, but before we do, I kind of want to show everybody what we're dealing with here. Here's the tube. You guys see this?
Yes, sir.
Those little black things are the hair from his beard. Just to give you an idea of scale, how big this is. This is 4mm wide. So we're going to take this out, and then you can actually see just how small it really is. Now we've lost probably 1 milliliter of blood. That's nothing, right, doctor? Okay. Did you hear that air leak? I'm just kidding. I'm going to apply pressure just for venous, potentially any venous bleeding there might be. And then I'm going to show you guys. Now, I've done cervical on the neck Deuk laser disc repairs for 16 years now. We've never had a complication, not on a single patient. And we've gotten rid of, now lately we get rid of 98% of people's pain in their neck, their head, their headaches that come from the neck, and their arm symptoms. These are herniated discs, right? What are these things? Or are those part of the towel? All right, so the disc herniations pile is here. Okay, right here. You see that? Anyway, I've done 600 of these surgeries, and in 16 years. Look at the incision, guys. See that, Kevin?
Yes, sir.
Pretty cool, huh? 4mm. That's a Band-Aid right there, and we're done. This patient's going to go home in 45 minutes to an hour. Of course, they can't drive a car today. But they can start driving tomorrow. If you have any questions about the surgery, feel free to type them up now, and I'll come and answer them for you live. I'll be there in a few minutes. Why don't you go ahead and run a comparison of anterior cervical discectomy and fusion versus the Deuk laser disc repair, so people can see the difference. Can you do that?
Yes, sir.
Thank you. I'll be right there.
Spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a ½ inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
Dr. Ara Deukmedjian here at Deuk Spine Institute, and it's Groundhog Day, I believe, right? February 2nd, so 2/2/2022. And I'm here with one of my patients who traveled from, where did you come from?
Tennessee.
Tennessee. And why would you travel from Tennessee to Florida to Deuk Spine Institute?
I have been miserable for months, and I found you and did a consult with you and knew this is where I needed to come for good treatment and relief.
And what kind of problem were you having that brought you to Deuk Spine Institute?
Severe lower back pain, which turned into sciatica, and it was down my left leg constantly. I slept about 2-3 hours a night at most, and I could not sit for more than 5 minutes, and I had to be standing up.
And did you try some other treatments in Tennessee or elsewhere?
I did. When this whole thing started and it was a bad flare, I thought I'll be able to work through this. Chiropractic, physical therapy, 2 spinal injections, massage therapy.
And how did you know those treatments did not work for you?
I had no relief at all. My sleeping continued to get worse, and my pain was never better.
And do you have relief now?
Absolutely. I would say I have 95% relief.
Awesome.
And it's amazing. After surgery yesterday, I put on a back brace. I walked out of here. I sat down yesterday for probably over an hour and had lunch. Last night, in bed, I had 0 pain. It's a miracle.
Well, we're very happy that you're doing so well. And your surgery was a great one because we fixed 2 discs. You had herniated disc at L45, L5S1, and you can see in this footage right here that we grabbed the herniation out, and it was one of the herniations was really big, and it was really gratifying to get it off because it was resting on your sciatic nerve. Once we took it out, I think your sciatic nerve probably felt a sigh of relief.
Yes, absolutely.
Yeah, and the surgery went very well. The laser debridement of the annulus went well, and I feel like your pain's going to be gone. It's not going to come back.
I would agree.
All right, very good. Well, is there anything else you want to tell your viewers?
Folks, if you're suffering and you're not getting relief from those non-invasive therapies, then come see Dr. Deuk and have him look at your MRI and give a good diagnosis. And if you need to have surgery, you come down here. He will take good care of you, and so will his team.
I really appreciate that. Thank you so much.
Thank you.
I'm Dr. Ara Deukmedjian. It's January 26, 2022, and I'm here with one of my patients who you underwent the Deuk laser disc repair on your lower back for some herniated discs about a week ago.
Yes,
How are you feeling today?
unbelievable. For almost 3 years, I had lower back pain, and it just, it just nags at you, wears you out. And then I came here, and you were the first one. I went to 2 other surgeons, and neither one of them picked up what was wrong with me, even though I had the MRI. And you came in, and you told me exactly what was going on, and you performed the laser surgery, and I'm like a different person.
Yeah.
A week later.
Yeah, you were a different person the next day, right? The day after you had no pain, remember?
Absolutely.
Yeah, so that pain's gone for the rest of your life. How does that make you feel?
New life.
Good. And, a long time ago, remember when people did something great, you say, what are you going to do now? They say, I'm going to Disneyland. You already went, I can see.
No, my wife's a big Disneyland fan.
Good for you. All right, so sounds like we helped you with your back pain, and it sounds like you're very satisfied.
Oh yeah, I'm recommending a friend of mine in Connecticut to come here. You have to come here. If you go anywhere else, I really think you're going to be wasting your time. So this guy just looks at you, and he can tell what needs to be done. He's a fantastic talent, and I'm very grateful that I came here.
Well, we're grateful you did too, because it's going to change your life for the better. Congratulations.
Thank you, Doc.
You're welcome. Good morning, I'm Dr. Deukmedjian. I'm here with one of my patients, and you traveled to Deuk Spine Institute here in Florida from where?
New York, Poughkeepsie, New York.
Awesome. And why did you come from New York to Deuk Spine here in Florida?
Because I heard that this was the best place for me to go.
What kind of problems were you having that you needed to come here?
I had lower back problems and numbness in my leg, which was my left leg. This was the best place for me to come.
Okay. So you had back pain, sciatica down your left leg, pain shooting down the left leg.
Yes.
And that was just yesterday, right? When you
yes,
had
that's
that.
correct. Yeah.
And what, do you still have your back pain today?
No more back pain.
It's gone.
Go on.
And is that because we have you doped up on powerful painkillers?
Nope. None
No, it
whatsoever.
isn't. Did anybody in New York offer you spine surgery to fix your back?
Yep. Yes, they did.
Yeah.
And they wanted to fuse it.
Yeah. And you've had surgery before. You had a microdiscectomy, and that helped you for a little while,
Yes.
but the symptoms came back.
Came back.
Yeah. All right. Well, they're not going to come back this time. So what do we do to make your pain go away?
You fixed my back. I did orthoscopic.
That's right. Arthroscopic spine surgery called the Deuk laser disc repair. So leg pain's gone, back pain's gone.
Everything is gone.
You happy?
You did. Very happy.
You're smiling.
Yeah. I tell you.
Congratulations.
Thank you so much.
We did it all through a 7mm incision, just that big. And you can actually watch that video right here, an animation, to see what it looks like to do the Deuk laser disc repair.
A Band-Aid sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own.
So now that your surgery's done, what are you going to do?
I'm going to go home and enjoy my life.
Good for you.
Enjoy my life.
Congratulations.
I'm very happy.
Anything you want to tell your viewers?
Other than this is the place to come, it's worth the travel.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs. Deuk laser disc repair, a comparison with traditional spinal fusion surgery. Deuk laser disc repair,